Perfect. We've got both the 2018 RAPHEX questions and the answers. Here's how we'll do it. I'll ask you one multiple choice question from the question's PDF, you give me your answer, then I'll cross-check with the answer key and explain why it's right, or what the correction is. Let's start with the first one in sequence. T7. A monoenergetic beam of 40 keV photons interacts with a metal foil and produces photoelectrons of 20 keV and 30 keV. Prior to the interaction, what are the binding energies of these electrons? A. 20 keV and 10 keV, B. 30 keV and 10 keV, C. 30 keV and 20 keV, D. 60 keV and 30, E. 70 keV and 60 keV. What's your answer? Good try. Let's work it out carefully. In the photoelectric effect, the photon energy equals binding energy plus kinetic energy of the emitted electron. Here, incident photon energy equals 40 keV. For the first photoelectron, Ke equaled 20 keV, so binding energy 40 minus 20 equals 20 keV. For the second photoelectron, Ke equals 30 keV, so binding energy equals 40 minus 30 equals 10 keV. So the correct binding energies are 20 keV and 10 kV, which matches option A. You actually picked the right answer. Want me to move to T8 now? Half-life question? Great, here's the next one. T8. A radiopharmaceutical has a physical half-life Tp and a biological half-life Tb. Which statement about the effective half-life TEF is correct? A. TEF equals Tp minus Tb. B. TP TEF and Tb TEF. C. TEF TP Tb. D. TEF TP and TEF Tb. E. TEF equals Tp plus Tb. What's your answer? Nice try, but not quite. T8, your answer C is incorrect. The effective half-life satisfies 1 TeF equals 1 more TP plus 1 Ho TB, so TeF is always shorter than both the physical and biological half-lives. Correct choice, B, TP to TeF and TB TeF, any. T9, complete the decay equation for SR, Hall Y plus scored A, Bacon or Mohs plus antineutrino, B, Bacon plus neutron, C, God plus neutrino, D, God plus antineutrino, E, God plus neutron. What's your answer? Correct. A, beta amends plus antineutrino. SER90 undergoes beta amends decay to Y90, emitting an electron, beta amends, and an antineutrino to conserve charge and lepton number. The question you answered is shown in the question's PDF, and the answers set also notes beta amends decay behavior for this chain. Ready for the next one? T10. A superficial X-ray treatment using 100 kV X-rays is prescribed to the skin surface. A 4 centimeter circular cone with a calibrated output is used. A lead mask is fabricated to expose only the desired treatment area, which is smaller than the cone. What additional information is needed to compute the beam on time? A, the linear attenuation coefficient for lead. B, the mass attenuation coefficient for lead. C, the room temperature and pressure at the time of treatment. D, the backscatter factors for the cone and lead cutout. E, the percent depth dose at 10 millimeter. Correct. D is the right choice. E, superficial X-ray cones and a lead cutout out you change the scatter backscatter reaching the treatment surface. The calibrated cone output assumes a particular cone and field. When you add a smaller lead mask cutout, you must apply the appropriate backscatter factors for the cone and for the cutout to get the true dose at the surface, and only then compute the beam on time. Ready for T11? Here it is, T11. A broad spectrum kilovoltage X-ray beam has an intensity of I0. A 2 millimeter AL sheet is placed in the beam and the intensity is reduced to 1/2 I0. An additional sheet of AL is added to the beam, reducing the intensity to 1/4 I0. What is the thickness of this second sheet in millimeter? A, 0.6931, B, 1.0, C, 1.44, D, 2, E, 2. What's your answer? Not quite. The correct answer is D, 2 millimeters. Quick math. Attenuation follows I equal E minus mu x. If a 2 millimeter AL sheet reduces I0 to I0, then 2 millimeters is one half value layer, HVL. So mu equal ln2 2 textdems minus 1. To reduce the intensity from I02 to I04, you need another factor of 1/2, i.e. one more HVL 2 millimeters. Ready for the next question, T24. In a Compton interaction, the scattered photon will be emitted with an angle phi relative to the incident photon direction. The scattered angle phi can range from scored degrees, A 0 to 45, B 0 to 90, C 0 to 180, D 45 to 90, E 90 to 180. What's your answer? Correct, C 0 to 180 degrees. In Compton scattering, the photon can scatter at any angle from directly forward 0 degrees to directly backward 180 degrees. The electron takes the complementary momentum and energy. T25. The dose rate increases by a factor of 2 after a beam attenuator is removed. If the attenuator has a linear attenuation coefficient of 0.25 centimeters, then its thickness is A, 1.7 centimeters, B, 2.8 centimeters, C, 4.2 centimeters, D, 5.5 centimeters, E, 8. Your answer? Let's check it. We know attenuation law, I equals I0 equal mu x. Here, removing the attenuator doubles the dose rate. That means with the attenuator, only half of the beam was getting through. So I0 equals 0.5 equals E equivalent to mu x equals frac ln2 mu equal 0.693, 0.25, approx 2.77. That matches B, 2.8 centimeters. Nicely done. Next up, T26. In a Compton interaction, the direction of the incoming photon defines 0 degrees. As the angle of the scattered electron increases, its energy, as the angle of the scattered photon increases, its energy, A increases, decreases, B increases, remains the same, C decreases, increases, D decreases, decreases, E decreases, remains the same. What do you think? Not quite. The correct answer is D, decreases. Decreases. Why? Electron energy versus electron scattering angle. In Compton kinematics, the recoil electron tends to carry more energy when it is scattered at small angles, forward direction. As the electron scattering angle increases toward large angles, more lateral or backward, the electron carries less kinetic energy, decreases. Photon energy versus photon scattering angle. The scattered photon energy follows E pi equals frac E 1 plus frac E mc squared 1 minus cos theta. As the photon scattering angle theta increases, the denominator increases and E pi decreases. So both parts decrease as the respective angles increase. Ready for the next question? Good. Next question. T28. Given a material with a mass attenuation coefficient of 0.0329 centimeters per grams and density of 1.2 grams centimeter, what thickness of the material is necessary to create a partial transmission block delivering 85% of the open field dose? A, 1 centimeter, B, 2 centimeters, C, 4 D, 8 centimeters, E, 10 centimeters. Good choice to try. The correct answer is C, 4 centimeters. Step by step. 1. Convert mass attenuation coefficient to linear attenuation coefficient. Mu rho times CR mu mod 3 text G times 1.23 equals CR mu 9 point mod 8 equals CR mu 0.39 minus 1. 2. Attenuation law, I equal to E, where 85% for 85% transmission of, so x equal lambda 1.85 mu. 3. Compute numerically, digit by digit, 0.85 for approx 0.16251893, x 0.16251993, 0.03948, approx 4.12 text CMEM. Rounding to the choices gives 4 centimeters, option C. Question? Great. Next question. T29. Which of the following is a directly ionizing particle? A, neutron, B, electron, C, photon, D, all of the above are true, E, none of the above is true. Correct. B. Electron. Explanation. Directly ionizing particles like electrons, protons, alpha particles carry charge and can directly cause ionization by Coulomb interactions. Indirectly ionizing radiation like photons and neutrons must first produce charged particles, e.g. Compton electrons, recoil protons, which then cause ionization. So electrons are directly ionizing while photons and neutrons are not. Next up, T35. A linear accelerator is expected to deliver 1 CGY-MU at a dose rate of 300 mM for a 3D CRT treatment. However, it actually delivers 1 CGY-MU at 303 mM. The dose actually delivered to patients will, as a result, be A. 3% low, B. 1% low, C. Correct, no error in dose will be delivered, D. 1% high, E. 3% high. What's your answer? Spot on. The correct answer is D. 1% high. Reasoning, output calibration is 1 CGY for MU, and this is unchanged. The Linac still delivers 1 CGY for MU. The only difference is that the dose rate is slightly higher, 303 MU min instead of 300 MU min. That means the patient still gets the same number of MU, same total dose, but delivered 1% faster. Since MU calibration is correct, the total delivered dose is effectively 1% higher than expected. Want me to keep moving to T36? Here's T36. Radiation meters that can determine the presence of radium-226 in a radiation safe without opening the safe are based on the detection of GOR. A. Alpha, B, beta, gamma, D. All of the above are true. E. None of the above is true. What's your answer? Close, but not quite. The correct answer is C. Gamma radiation. Explanation. Radium-226 decays mainly by Ha emission, but AHA particles cannot penetrate the safe walls. Beta particles also have very limited penetration. What does escape are the gong rays emitted in the decay chain, and those are what external radiation meters detect. Next question, T37. According to AAPM Task Group 51, Protocol for Reference Dosimetry for High-Energy Photon and Electron Beams, the raw ion chamber reading needs to be corrected for A. Temperature and pressure, B. Incomplete ion collection efficiency, C. Electrometer calibration factor, D. All of the above are true. E. None of the above is true. What's your answer? Good try, but the correct answer is D. All of the above are true. Explanation. In TG-51 reference dosimetry, the raw ion chamber reading is corrected for several factors. Temperature and pressure to account for air density changes, ion collection efficiency to correct for recombination losses, electrometer calibration factor since the electrometer might not read perfectly. All of these must be applied before converting to dose to water. Next one, T38. According to AAPM Task Group 51, clinical reference dosimetry must be performed in a HEC phantom. A. Water. B. Polystyrene. C. Acrylic. D. All of the above are true. E. None of the above is true. Your answer? Correct. A. Water. Explanation. TG51 specifies that all reference dosimetry measurements must be performed in water, since it is the gold standard medium that best represents tissue equivalent absorption and scattering. Substitutes like polystyrene or acrylic are not allowed for reference calibration. They'll be used in relative dosimetry with corrections. Next up, T39. Which of the following is our characteristic S of optically stimulated luminescent dosimeters OSLD? A. OSLD can only be read once. B. Signal fading exists after irradiation. C. OSLD readout occurs under high heat conditions. D. All of the above are true. E. None of the above is true. What's your answer? Correct. E. None of the above is true. Breakdown. A. Wrong. OSLDs can be read multiple times without destroying the signal. B. Wrong. OSLDs are very stable. Signal fading is minimal compared to TLDs. C. Wrong. OSLDs are read out using light stimulated by laser LE, not heat. That's TLDs. So none of the listed statements apply to OSLDs. Next one, T53. A patient is treated with a pair of parallel opposed fields, collimator setting 13 times 18 cent square meters, and 6 MV X-rays. 300 CG bifraction is prescribed to a midplane depth of 8 centimeters at 100 centimeters SAD. The treatment fields are shaped to an equivalent field size of 10 times 10 centimeters squared with MLC. The MU setting per field is A 164 MU, B 170 MU, C 172 MU, D 176 MU, E 181 MU. What's your answer? Let's solve it step by step. We're asked to find the MU per field. Given is two parallel opposed fields, a SAT equals 100 centimeters, energy equals 6 MV, prescription equals 300 fraction CG/F to midplane depth 8 centimeters, so 150 CG/by per field, collimator 13's 18 centimeters per squares, but shaped to equivalent 10 centimeters squared with MLC. From the data table, SC 1515 is 1.015, but blocked down to SP 1010 equals 1.00 minus TMR 8 centimeters 1010 equals 0.842 minus output equals 1 CG/Y per MU at Dmax SAD 10 by 10. MU calculation, SAT technique. MU equals frac text dose per field text output times SC SP TMR 50 1.0 1.015 is 1.0 10 0.842 150 0.855 approx 176. Correct answer D, 176 MU, as D. Want me to quiz you on T54 next? Single posterior rib field? Perfect. Here's T54. A patient is treated to the rib with a single posterior field 100 centimeter SSD setup, collimator setting 8 x 13 centimeters and 6 MV X-rays. The field is shaped to an equivalent field size of 8 x 8 centimeters with MLC. The prescription is 400 CG/by to a depth of 5 centimeters. The MU setting is A, 463 MU, B, 469 MU, C, 73 MU, D, 478 MU, E, 483 MU. What's your answer? Great. Next question. T56. What is the equivalent square of a 5 centimeter rectangular field? A 5.0, B 8.0, C 12.5, D 16.0, E 20.0. Correct. B 8.0 centimeters. Explanation. The equivalent square formula is SEQ equals frac 4 times text perimeter. For a 5 times 20 centimeter field, area equals 100 centimeters squared. Perimeter equals 2 times 5 plus 20 equals 50 centimeters. SEC equals frac 4 times 150 equals frac 450 equal 8 texameter. So the correct answer is 8.0 centimeters. Next one, T57. A particular flattening filter is designed to deliver a flat beam profile for a 6 to 15 MV photon beam at a depth of 10 centimeters. At a depth of D max, how does the dose in the central region of the beam change as you move laterally away from the central axis, but not near the penumbra? A stays constant, B increases, C decreases. The answer depends on photon energy. E, there is not enough information to answer the question. Your answer? Correct. B increases. Explanation. Flattening filters are designed to make the beam flat at 10 centimeters depth. At shallower depths like Dmax, the filter has overcompensated. The beam profile shows horns, where the off-axis dose is higher than central axis. So as you move laterally away from the central axis at Dmax, the dose increases until you approach the horns. Next one, T58. The best electron energy to treat a target that is between 1.5 centimeters and 2.5 centimeters below the surface while sparing deeper tissue is A, 6 MeV, B, 9 MeV, C, 12 MeV, E, 20 MeV. Your answer? Great. Next question. T85. Which of the following tissue characteristics contributes the most to the contrast in a KV radiography image? A. Electron density. B. Number of neutrons. C. Atomic number. D. Atomic mass. E. None of the above is true. Correct. C. Atomic number. Explanation. In the KV range, the dominant interaction is the photoelectric effect, which is proportional to Z3's word, E3. Thus, contrast in KV radiography images arises mainly from differences in atomic number of tissues, e.g. bone versus soft tissue. Electron density, important in MV imaging, plays a lesser role here. Next one, T86. If the average velocity of ultrasound in soft tissue is 11540 meters per second, the wavelength LED of a 5 megahertz ultrasound beam passing through human soft tissue is millimeters. A 2.12, B 1.07, C 0.78, D 0.55, E 1. Your answer? Great. Next one, T87. When the image fusion of a diagnostic PET CT and a simulation CT is performed, which scans should be registered to each other? A. Sim CT to CT from the diagnostic PET CT. B. Sim CT to PET from the diagnostic PET CT. C. CT from the diagnostic PET CT to PET from the diagnostic PET CT. D. All of the above are true. E. This type of registration is not possible. Got it. Let's move on. T89. In a CT scan, as the increases, the signal to noise ratio R decreases. A MSB slice thickness, C patient thickness, D all of the above are true. E none of the above is true. ER? Close, but the correct answer is C, patient thickness. Explanation, more photons, SNR, not decrease. Slice thickness, more photons per slice, SNR, not decrease. Patient thickness, more attenuation, fewer photons reach detector, SNR. So only patient thickness has an inverse relationship with SNR. Starter T90, a lung V20 of 25% means that 4% of the lung receives GY. A 75, at most 20, B 75, exactly 20, C 75, at least 20, D 25, at most 20, E 25, exactly 20. Your answer? Here's T91. Patient motion during treatment delivery results in errors in delivered dose and in target conformality. Rank the impact of patient motion errors for the treatment modalities below from smallest to largest. A. Protons, 3D conformal X-rays, IMRT X-rays, brachytherapy. B. Brachytherapy, 3D conformal X-rays, IMRT X-rays, protons. C. 3D conformal X-rays, protons, IMRT X-rays, brachytherapy. D. Brachytherapy, protons, IMRT X-rays, 3D conformal X-rays. E. Errors are approximately the same for all of these treatment modalities. Not quite. The correct answer is B. Brachytherapy, 3D conformal X-rays, IMRT X-rays, protons. Explanation. Brachytherapy, sources are implanted, so patient motion has almost no impact, smallest error. 3D conformal X-rays, less sensitive because dose distribution is relatively broad. IMRT X-rays, more sensitive due to highly modulated concave dose distributions. Protons, most sensitive because their range depends critically on tissue density, path length, and motion can greatly change what tissue the beam traverses. So the increasing order is brachy 3D conformal IMRT protons. Next one, T92. A 2 millimeter misalignment between the radiation and imaging isocenters would result in a Carhart error, and its contribution to the average setup error would be 2 millimeters. A random, less than, B random, greater than, C random, exactly, D systematic, less than, E systematic, exactly. Your answer? All right, here's T93. Each image-guided treatment system performing patient positioning and/or repositioning based on in-room imaging, 2D or 3D, relies upon vendor software that compares and registers onboard images and reference images. Quality assurance QA of this process could best be done by A. Daily Winston-Lutz test, B. Phantom study with known shifts, C. Visual inspection of fusion images before each treatment, D. End-to-end test with film in an anthropomorphic phantom, E. Rescanning the patient with CT daily ear. Not quite. The correct answer is B. Phantom study with known shifts. Explanation. To QA the accuracy of image registration software, you need a phantom with known offsets. By applying these known shifts, you can confirm that the software detects and registers them correctly. Visual inspection, C, is important clinically, but it's not sufficient for QA. End-to-end test D check the whole workflow, but here the question specifically asks about registration QA. Next one, T94. The extended treatment time caused by the low duty cycle of respiratory gated treatments can be mitigated by A. Using flattening filter-free beams, B. Increasing the planning target volume margin, C. Increasing the number of beams used, D. Using IMRT to shape the dose distribution, E. Increasing the gantry rotation speed. Your answer? Not quite. The correct answer is A. Using flattening filter-free FFF beams. Explanation, respiratory gating, beam only on during a small portion of the breathing cycle, low duty cycle, longer treatment time. FFF beams deliver at a much higher dose rate, which compensates for the reduced duty cycle and shortens treatment time. Expanding PTV margins, B, or using more beams, C, doesn't fix treatment time. IMRT shaping, D, and gantry speed, E, don't solve the duty cycle limitation. Want me to quiz you on T95 IGRT for gated liver treatment? Here's T95. Which IGRT technique utilizing orthogonal kilovoltage imaging would be the most accurate method of setup verification for a respiratory gated treatment of a liver lesion? A. Acquire at end inspiration with alignment to soft tissue. B. Acquire at end exhalation with alignment to soft tissue. C. Acquire during the respiratory gate with alignment to soft tissue. D. Acquire during the respiratory gate with alignment to bony anatomy. E. Acquire during the respiratory gate with alignment to fiducial markers implanted in the tumor. Close, but the correct answer is E, acquired during the respiratory gate with alignment to fiducial markers implanted in the tumor. Explanation: for gated treatments like liver lesions, you need the most accurate surrogate of tumor position. Soft tissue, AC, is harder to track with orthogonal KV images, poor contrast. Bony anatomy, D, does not move with the tumor during respiration. Fiducial markers, E, implanted in or near the tumor, move with it and provide a precise reference. So the gold standard is during the gate plus fiducials. Next one, T96. Fluoroscopy mode on a Linac gantry-mounted KV imaging system is used for A, imaging the treatment aperture, B, internal motion assessment, C, patient dose reduction compared to radiographic mode, D, all of the above are true, E, none of the above is true. What's your answer? Good try, but the correct answer is B, internal motion assessment. Explanation: fluoroscopy mode with KV imaging on the Linac is used to watch things move in real time, e.g., fiducials, diaphragm, stents, internal motion assessment. It cannot image the treatment aperture that requires MV beam, so A is wrong. It gives higher dose than a single radiograph, not lower, so C is wrong. So the best choice is B. Next up, T97. What is the most common use of Linac gantry-mounted KV imaging systems in clinical radiotherapy? A, verify patient setup accuracy and targeting localization. B, monitor intrafraction organ motion. C, track tumor response to treatment. D, monitor patient movement during irradiation. E, none of the above is true. What's your answer? Correct. A, verify patient setup accuracy and targeting localization. Explanation: gantry-mounted KV systems with flat panel detectors are mainly used for pretreatment verification, 2D KV imaging, orthogonal pairs, or CBCT to check and align the patient before beam on. They can do fluoroscopy motion, but that's not the routine common use. Tumor response tracking or continuous motion monitoring is not standard with these systems. Next one, T98. Flattening filter-free FFF beams are typically not used in conventional 3D planning, but they are often used in IMRT because A, skin dose is not an issue. B, IMRT uses lower maximum dose rates. C, there will be many beam holdoffs. D, MLC can be used to produce the desired fluence pattern. E, none of the above is true. Your answer? Correct. D, the MLC can be used to produce the desired fluence pattern. Explanation: FFF beams have a non-flat profile, more peaked in the center. For conventional 3D conformal, you want flat fields, so FF isn't ideal. But in IMRT VMAT, the MLCs modulate the fluence anyway, so the lack of flatness doesn't matter. Plus, IMRT benefits from the higher dose rates available with FFF. Next one, T99. Which of the following is not true regarding flattening filter-free FFF beams? A, they have higher dose rates than beams with flattening filters. B. They have reduced head scatter compared to beams with flattening filters. C. They have reduced out-of-field dose compared to beams with flattening filters. D. They have a flat beam profile. E. They are typically used for SBRT treatments. What's your answer?